Welcome to Board Pearls. This is episode 3 of 3 of the GERD and Refractory Reflux chapter in the Esophageal Disorders module. This episode is the patient whose reflux drug has failed, the framework that separates real reflux from an oversensitive esophagus, the anti-reflux surgery that's only appropriate once you've actually proven reflux, and the workup of persistent symptoms, where the answer is usually not reflux at all. Picture the patient this whole episode is about, on twice-daily acid suppression for months, still burning. The instinct is to ask how to push harder, and that's the wrong question. The right question is what they actually have, because most people who fail a proton pump inhibitor don't have reflux that's breaking through. They have a different diagnosis wherein reflux is closed, and that other diagnosis has its own treatment. So both reflexes, more acid suppression or a surgical referral, fail more often than they help. The test that answers the real question is reflux monitoring, and the framework for reading it is the Lyon consensus, which grades the evidence for reflux into 3 levels: proof, support, and evidence against. The proof level findings are the ones that show the barrier has actually failed: long segment Barrett's, moderate to severe erosive esophagitis, a peptic stricture, or an acid exposure time above 6% on a pH study. On the other end, an acid exposure time under 4% on every day of the study is evidence against pathologic reflux. In between 4 to 6% is the borderline zone, and that's where the supporting measures earn their place. Those are things like a high count of reflux episodes over a day, around 80 or more, a low baseline impedance measured overnight when nobody's swallowing, which runs low when the lining has been chronically inflamed, with values under 1,500 supporting reflux and over 2,500 arguing against it, and a measure of how often a reflux event triggers a clearing swallow, which is low when clearance is poor. Separate from all the burden measures is whether the symptoms actually line up with reflux events, and there are 2 versions of that. One simply counts the fraction of symptoms preceded by a reflux event, positive at 50% or more, and the other is a more rigorous statistical test, positive at 95% or more, and that second one is the one usually invoked. Whether you test on or off the drug comes down to what you're trying to prove. If you don't yet know the patient has reflux, you're trying to demonstrate it exists, and having the drug on board would hide the answer, so you test off it, holding the drug about a week, usually with a wireless capsule clipped above the junction that records for a couple to a few days. The longer window, improving the odds of catching a symptomatic episode. If you already know they have reflux, from severe esophagitis or long segment Barrett's or a prior abnormal study, the question is different. Now you want to characterize what's breaking through despite suppression, so you test on the drug, and that study has to measure impedance, not just acid, because the breakthrough events on suppression are often weakly acidic or non-acidic, and a pure acid probe won't see them. Run that framework on a refractory patient, and they land in one of 4 groups, and the groups matter because their treatments diverge sharply. Confirmed reflux is an acid exposure time above 6%, and the symptoms can be pinned on the reflux. Borderline reflux is the 4 to 6 zone, where the diagnosis leans on those supporting measures. Reflux hypersensitivity is a normal acid exposure under 4%, but with symptoms that genuinely track the reflux events, so the esophagus is oversensitive rather than overexposed, and the treatment is a nerve signal modulator combined with acid suppression. And functional heartburn is a normal acid exposure, with no link between symptoms and reflux at all, which means it isn't reflux driving the symptom, so the treatment is a neuromodulator alone, and neither more acid suppression nor an operation helps. That last point is worth burning in. The most common reason a fundoplication fails is that the patient sent for it had functional heartburn, not reflux. That's exactly why proving reflux objectively before surgery is non-negotiable, and it sets up the surgical part of the episode, which is really about matching the right operation to the right patient. No one should go for a rap on drug failure alone. You need objective evidence of reflux first, meaning at least moderate esophagitis, long segment Barrett's, a stricture, or an abnormal off-drug study. Drug failure is a reason to work the patient up, not a reason to operate. Every fundoplication does the same thing mechanically. The surgeon pulls the hiatal hernia back down, brings the crura of the diaphragm together, returns a segment of esophagus to the abdomen, and wraps part of the top of the stomach around it, which rebuilds the natural flap valve angle, restores the abdominal pressure around the lower esophagus, reinforces the sphincter from outside, and blunts those transient relaxations by keeping the top of the stomach from ballooning open with meals. The only real choice is how much of a wrap, and that comes down to one question: can this esophagus generate enough force to push food past the wrap? A full 360-degree wrap gives the best reflux control because it closes the esophagus most completely, and its price is more trouble swallowing and more bloating, because a tight full wrap can't vent during a normal relaxation. So it's the operation for someone with normal esophageal muscle, and it's specifically wrong in scleroderma and other states with absent contractions, because a weak esophagus can't drive food past it. A partial wrap of about 2/3 leaves a strip of the esophagus uncovered, which lowers the resistance the wave has to overcome. So that's the operation for a weak esophagus, and scleroderma or ineffective motility get a partial wrap if they get any wrap at all. The reflux control is a little less complete in a normal motility patient, but that matters far less than the harm of putting a full wrap on an esophagus that can't handle it. A smaller anterior wrap is the one usually paired with a myotomy in achalasia, where you want a bit of reflux protection without undoing the sphincter you deliberately cut. And worth holding, good acid suppression is actually competitive with surgery in patients who respond to it, so surgery's real edge is controlling regurgitation and serving people who can't or won't stay on lifelong medication. The magnetic device is a ring of magnetic beads placed around the lower esophagus that holds the sphincter closed against the small pressure swings of breathing, but separates when a swallow pushes food through, then closes again. Its main advantage over a full wrap is that it preserves belching and vomiting, so much less bloating, and it's potentially reversible. But its exclusions are the testable part. A hernia over 3 centimeters rules it out. A BMI over 35 rules it out. And Barrett's, severe esophagitis, absent or badly impaired peristalsis, a metal allergy, and prior major upper GI surgery all rule it out. It's endorsed specifically for troublesome regurgitation that fails medication. The incisionless endoscopic fundoplication builds a partial wrap from inside with fasteners and avoids incisions entirely, but its candidacy is narrow. The hernia has to be under 2 centimeters. Severe esophagitis excludes it, and the best candidate is someone whose symptoms respond to medication and whose main complaint is regurgitation. Its durability past a few years is debated, and a combined version pairs a laparoscopic hernia repair with the endoscopic plication to extend it to larger hernias. The very obese patient with reflux is a separate track. The gastric bypass is the anti-reflux operation of choice because it diverts acid and bile away from a small stomach pouch that has little acid-making tissue, and it treats the obesity driving the reflux in the first place. A sleeve, by contrast, tends to cause or worsen reflux because it removes the top of the stomach and turns it into a high-pressure tube, so it's avoided in an obese patient who already has reflux, and someone who develops refractory reflux with erosive disease or Barrett's after a sleeve is converted to a bypass. A BMI over 35 also independently predicts fundoplication failure, which is the other reason obese refluxers go to bariatric surgery rather than a wrap. A few older endoscopic procedures show up mainly as wrong answers. Radiofrequency treatment of the junction has only modest sham-controlled results and isn't routinely recommended. Injection bulking agents are off the market, and a couple of newer devices are still investigational. The pre-surgery workup is the same no matter which procedure you pick, and it's mandatory. Endoscopy to document the esophagitis grade and hernia size, and to exclude Barrett's, eosinophilic disease, and cancer. A pressure study to confirm the muscle works, or to document the weakness that forces a partial wrap, and to make sure you're not operating on an achalasia hiding as reflux. And a provocation on that study, a run of rapid swallows to test whether the muscle has reserve, where a strong response afterward predicts tolerance of a full wrap and a flat one pushes you to a partial. And you need off-drug reflux monitoring if reflux hasn't already been objectively proven. Afterward, the complications to know are the slipped wrap, the too tight wrap, bloating, and the junction telescoping up through the wrap, and a suspected wrap failure is evaluated first with a barium swallow, because it shows the wrap shape in a way the scope can't. Now, the actual workup of the refractory patient, which runs as an ordered set of steps, each one asking whether the diagnosis is really what we think before escalating. The first step is the cheapest and is never skipped. Confirm the drug is being taken right. These are prodrugs that only work on pumps that are actively pumping, and pumps switch on at meals, so the drug has to be taken 30 to 60 minutes before breakfast, and before dinner too, for twice daily. Someone taking it at bedtime, with food, or whenever they remember is essentially untreated, and when this was studied, a real share of supposedly refractory patients got better just from fixing the timing. The second step is to escalate suppression. Move once daily to twice daily before meals. Switch to a stronger agent, which matters most in the fast metabolizers who clear the weaker ones too quickly. and reach for vonoprazan for genuine breakthrough in someone who's truly failed twice-daily dosing taken correctly, since it blocks the pump in a steadier, meal-independent, more complete way. A bedtime histamine blocker can be added for documented nighttime breakthrough, as a short-term measure because it fades within a few weeks. The third step is endoscopy with biopsies, even if a prior scope was normal, and the biopsies are the non-negotiable part, taken high and low. The reason is eosinophilic esophagitis, which causes drug failure, is defined under the microscope at 15 or more eosinophils per high-power field and can look completely normal to the eye in a meaningful minority, so a normal-looking scope without biopsies misses it in exactly the patients who have it. This scope also documents hernia size, looks for Barrett's, and rules out structural disease. The fourth step is reflux monitoring, on or off the drug depending on whether pathologic acid exposure is already proven. Read through the same framework and cutoffs, which separates the patient into confirmed disease, borderline, reflux hypersensitivity, or functional heartburn. The fifth step is where most of the real diagnostic work lives, asking whether the patient has reflux at all or one of the conditions that imitate it. Functional heartburn, normal acid exposure, and no symptom link gets a neuromodulator, a low-dose tricyclic, or an SSRI or hypnotherapy, not more acid suppression and not surgery. Reflux hypersensitivity, normal exposure but a real symptom link, gets a neuromodulator plus acid suppression. Because the patient is genuinely feeling physiologic reflux, the esophagus reads as painful. Rumination is effortless regurgitation of just eaten food, starting within 10 or 15 minutes of a meal, re-swallowed or spat out, with no nausea or retching, and on a pressure study, you see the abdominal strain event, belly and esophageal pressure rising together with the sphincter opening at the same moment. The treatment is diaphragmatic breathing from a behavioral therapist, not acid suppression and not a wrap. Supragastric belching is air sucked into the esophagus and pushed right back out without ever reaching the stomach, often mistaken for reflux, and on impedance the air clearly enters and leaves from above without crossing the sphincter. The treatment is speech therapy. Achalasia can look like reflux when food and saliva ferment above a sphincter that won't relax, and the pressure study is what excludes it. And eosinophilic esophagitis is the structural mimic the biopsies were there to catch. A few add-on medications help selected confirmed reflux patients still symptomatic on good suppression. Baclofen at 10 mg 3 times a day stimulates GABA-B and cuts down the transient relaxations, reducing both acid and non-acid reflux, so it helps troublesome regurgitation and persistent non-acid reflux, with drowsiness limiting how far you can push it. Alginate forms a foam raft that pushes the after-meal acid pool down away from the junction, so it helps postprandial breakthrough and works as an add-on in non-erosive disease. Sucralfate coats injured mucosa and is the preferred add-on in pregnancy, where the systemic drugs are second line. Antacids are for on-demand relief and don't heal erosive disease. Surgery is the last step and is reserved for the small group with objectively confirmed reflux-related symptoms after the mimics are excluded. When this was actually put to a trial, surgery clearly won in that small, carefully selected group of truly refractory reflux patients. But the more important lesson was the other one. Most of the original pile of referrals should never have reached a surgeon at all because they had timing failures, functional heartburn, reflux hypersensitivity, eosinophilic disease, motility disorders, or rumination. That trial is the single best argument for doing the structured workup before anyone gets referred. One caution before we close on the atypical presentations: the chronic cough, the laryngitis, the asthma, the dental erosion. Their link to reflux is much weaker than typical heartburn. The response to empiric acid suppression is low, and reflux of the larynx is overdiagnosed on laryngoscopy because most healthy people have some laryngeal finding that gets blamed on reflux. So you need objective reflux testing before committing a patient with isolated cough or laryngitis to long-term suppression, and fundoplication does worse for these atypical symptoms than for classic heartburn. So the way to think about all of it: drug failure is not refractory reflux. It's a reason to work the patient up, and the workup mostly turns up something other than reflux. The framework, with its acid exposure cutoffs and its symptom association test, separates persistent symptoms into confirmed reflux, borderline, reflux hypersensitivity, and functional heartburn, and those four diverge in treatment, which is what makes getting the category right so important. Anti-reflux surgery is matched to the patient on proven reflux and on motility, a full wrap for normal muscle, a partial wrap for a weak one, the magnetic device for select anatomy with troublesome regurgitation, the incisionless procedure for small hernias without severe esophagitis, and a bypass for the obese refluxer. And the refractory workup runs in order: timing, escalation, scope with biopsies, reflux monitoring, and the deliberate search for the mimics, because each step is really asking whether the diagnosis is what we assumed, and most of the time it isn't. That closes the reflux chapter. Next we move from the inflamed esophagus to the columnar one, where visible salmon-colored lining plus intestinal metaplasia defines Barrett's. There, the degree of dysplasia sets the surveillance interval, endoscopic treatment resects the visible disease and then ablates the rest, and cross and flot are the regimens for the cancers that arise from it. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 3 of chapter 3, and I'll see you in the next one.